Good afternoon. I think that's the last talk of the day. And then after this, we are going to University of Miami. I think let's start because we are running out of time. And I'm coming from University of Colorado, Barbara Davis Center for Diabetes. And I will be talking about today rapid-acting insulins and the inhaled insulin. I think I'll just change from here. This is not moving. I'm not sure why, but it's not moving from either. From here. Okay. Yeah. So these are my conflict of interest slides that I do research with most of the companies. And if we start with the glycemic management, as we know from the T1D exchange data, that's the most famous publication of the recent years, that despite all these advances in the diabetes technologies and the new insulins, we cannot achieve the ADA targets. Unfortunately, only 21% of the adults are meeting the ADA goals, which is less than 7%. And 37% achieve the A1C less than 7.5%. And the average A1C increased in recent years from 7.8 to 8.4%. And you see that in the certain ages that we are having larger issues that with the younger people that their hemoglobin A1Cs are high, but still in people are in these 30s and 40s, A1Cs are still high. So we need a better management strategies despite all these newer insulins and advanced diabetes technologies. And we all know that achieving a postprandial blood sugars that the target is actually even harder. So, and it's all a conversation that which one we should be focusing on. We should be targeting the postprandial glucose, or we should be targeting the fasting glucose. And there are so many different studies, and actually there are older studies are talking about which one is far more important. But today's talk is about the postprandial blood glucose control, so I'm just going to focus on that. So postprandial glucose management is complex and related to many things, and related to, especially in type 1 diabetes, that the importance of GLP-1 and GIP-1 is very important. Now we have medications actually to target these pathways too. And if you see that actually the more rapid gastric emptying increases the postprandial glycemia, and then acute hyperglycemia slows the gastric emptying while the hypoglycemia accelerates it. So it really depends a game that the timing of the insulin and the amount of the insulin and how fast your system is, GI system is. So effect on postprandial glucose on A1C, even though these are the older studies and done with most of the SMBGs, and these are the finger stick studies, you see that the effect of the postprandial glucose on the A1C is actually increases when your hemoglobin A1C is lower. It means that for our patients that are the A1Cs are higher, it's mostly a basal issue. And for the people that are actually lower A1C is actually mostly a postprandial blood glucose issue. So it shows the importance of the postprandial glucose control in the effect on the decreasing the A1C less than 7. Even though, as I said, this is like an older studies, and the recent studies are also showing that we just published a paper last week that actually that in most of the CGM data shows that postprandial glucose and the fasting glucose is actually contributing almost equally, but it's a focus on the postprandial glucose. Today we will be talking. So common problems with the insulin injections, the engagement and involvement. So we have patients that are diagnosed with type 1 diabetes, or if they have type 2 diabetes, they are using insulin. They really need to be motivated to use insulin. So there are a lot of misinformation about insulin, and there is lack of support. And there are injection problems, and a lot of people say that I'm using injections and for many years, and I asked them that, can you just show me how they are injecting? And they are just literally trying to inject in 2 seconds, and they are removing their pen. So another problem is the lipohypertrophy. You know, if the patients are keep using the same location, especially with the right-handed people, I always look at the left side because they keep using the same site, and you see this gigantic bulge there that when you do a physical exam, that's another problem. For especially younger people, needle anxiety is sometimes always an issue. And then the people are that, you know, they don't want to give a lot of injections and they don't eat too much just to not to get injections. And they always try to choose the size of the needle. You know, this is a little more painful, this is less painful. And the timing of insulin, I think that's the most important part from my perspective, because even if I look at the CGM, I can see that when this patient is giving this rapid acting insulin, that is it covering this meal or not? What's the timing? So they should be giving at least 15 minutes before. Otherwise, you see from your clinical practice, 10 to 20 minutes that it's not going to work. So carrying, traveling with needles, sometimes an issue. You know, we are giving the TSA letters and people are just going places, forgetting things. And also fear of hypoglycemia is I think one of the biggest barriers to control the postprandial blood glucose. In any type of insulin, I think people try to underdose in fear of hypoglycemia because they think that they may not be calculating properly their carbs and they are eating outside in a restaurant. They may not know how much, you know, the amount of the carbs, and they don't know when the food is coming. So the timing and the fear of hypoglycemia, it causes an issue that they tend to decrease their, unfortunately, the bolus insulin intentionally. So there are a lot of studies show that up to 20% of the people are actually missing their injections, and lipohypertrophy that causes a big problem. And timing of insulin is one of the main reasons to not to get a good postprandial glucose achievement. And needle anxiety, social stigma of type 1 diabetes, especially younger adults in the people who are going to school and college, and fear of hypoglycemia that I already mentioned. So insulins, how should we classify? So they classify this rapid acting insulin analogs 20 years ago, and they called them rapid insulin analogs. But now we have too many different insulins. So I classified like this, which I don't agree. And then because I don't think these are the insulins are rapid insulin analogs anymore. So if we call them rapid insulin analogs, how about the others? Which one should be called ultra-rapid insulin analogs and why? What's the definition of rapid and what's the definition of ultra-rapid? And how fast an insulin should be that we should call rapid or versus ultra-rapid? So again, I said, I don't agree this classification because I don't think that we can make this anymore. And I think we should be really focusing on the effect of the insulin and how fast they are with their PK/PD studies. So if we start with the fast-acting insulin aspart, which is the FIASP, and this insulin is basically an insulin aspart with vitamin B3 and L-arginine, and the vitamin B3 and increases the absorption, and the L-arginine is this stabilizer. And you see this PK/PD studies that it's a little bit more faster than the competitor insulin aspart, the faster aspart. And you also see that it leaves a little bit sooner, but not too early compared to the insulin aspart. And there is an 11 minutes in this PK study, and then there's a 35 minutes at the end. And but there you still see the tail up to the 300 minutes at the end. So the other insulin, that the fast-acting insulin aspart, I think that's one slide we are down. Okay, we are still in the FIASP, sorry. And the fast-acting insulin aspart, if you see the effects in the onset studies, and the onset is going 1, 2, 3, 4, 5 right now. And if you look at all of them are similar, and you see that the better postprandial glucose excursion in the first and the second hours. And if you give it at the meal time at the same time you see in the first one, and the second one, you see that if you give after the meal is actually not better than that. So the timing of insulin, even though we call this one rapid or ultra-rapid action insulins, you still need to bolus before meals, even though they have some FDA indications that they can be some of them used at the same time or a little bit later. If you look at their studies that they got the FDA approval and they met the non-inferiority margin, which is less than 0.4% A1C for the FDA. And so they had the similar A1Cs. On the right side of the slide, you see that the faster aspart FIASP is giving with the blue with the post-meal. And one below that in the insulin aspart is the insulin, which is the Novolog comparison, is the mealtime. And the lower one is giving the faster aspart at the mealtime. You see that if you give the faster aspart, if the meal actually it's worse than the comparison, the insulin aspart. So you have to still need to give the mealtime to see a little bit better results, which didn't reflect to the A1C as a superiority in long term. And none of the onset trials actually showed a difference in the 24-hour in the time in range and also A1C benefit. So if we go to the insulin Lispro AABC, which is the Lumjev, and you see that there are two main ingredients that we see, which one is the prostaglandin, which is the treprostinil. Other one is the citrate. Citrate is the enhancing vascular permeability, and the prostacyclin analog causes the local vasodilatation, so it can absorb a little bit quicker. So if you compare this PK/PD with the comparison of the insulin Lispro, if you see that it's affected a little bit faster, and also the tail is not as long as the FIASP. And you see that PD is also a little bit different compared to the FIASP one. So, and it's a little bit, relatively speaking, faster insulin, even though we cannot compare one by one like this. So how about the Pronto studies? I have been an investigator in all the Pronto studies, Pronto type pump and Pronto pump 2. And in this study that we did is a multi-center study, is a very similar design with the FIASP studies and very similar results you can see with the onset studies. Better postprandial glucose excursions in the first and second hours. Then after that, there is not a meaningful difference in the after hours. And you see that it's a similar A1C, means that met the non-inferiority criteria, but it was not superior compared to insulin Lispro. And if you see that the same one, that the same design with the post meals and meal time, and at the same time with the comparative insulin Lispro, there is not a huge difference if you give after meals, especially if you give after meals, actually it can be a little bit worse. So if we compare the insulins that affect about their time, how about the circulating endogenous insulins, time to measurable effect is about 10 minutes, and the inhaled insulin is about 12 minutes, and the injectable ultra-acting insulins are 17 to 30 minutes. And time to peak about 45 minutes, and both for the inhaled insulin and endogenous insulin. And the injectable insulin is about 90 to 120 minutes. And time for effect to return to baseline is 210 versus 180. The other FIASP and Lumjev is 275 and 320 minutes. So you see that they actually a little bit, you see the tail for that rapid-acting insulins. So the common problems with the injectable ultra-rapid insulins are injection site problems and infusion site problems. All of the onset trials and the Pronto pump 2 studies showed some increasing redness, pain, and itchiness during the injection site or the infusion site in all studies. And it was the most common reason to leave the study for that, including with the occlusion in some of the pumps. And high cost insurance coverage problems, I think this is also a problem compared to the first generations Novolog and Hemolog. And I think from my perspective, is biggest issue is the no effect on the 24-hour A1C, the 24-hour time in range and the A1C in the major clinical trials. So they were not superior to rapid insulin analogs, even though in their follow-up studies, they showed that a secondary analysis in a small amount of people, in the higher A1C patients, they showed a little benefit, but it didn't, there was never a primary or secondary goal in that study. Right now, we are doing the Medtronic 780G pumps with the FIASP and the Lumjev. There is a compatibility study, and we are doing the tandem pumps with the Lumjev compatibility study. Right now, the FDA is requiring that all this rapid-acting new insulins, that is a compatibility study with the current pumps. So we don't have the results yet because 3 of the studies are still going on. So if we move the inhaled insulin, and inhaled insulin absorption is so much different than obviously the injectable insulin. So because that ultra-rapid acting insulin pulmonary delivery is less than 1 minute because of the monomeric insulins, and it is a regular insulin, and monomeric insulin diffuses into the systemic circulation more rapidly than their larger counterparts. If you see that here, that compared to long-acting insulin versus the rapid-acting insulin and the ultra-rapid-acting insulin, that you see that the differences in between that all these insulins in terms of that going to the blood system. So inhaled insulin, it mimics the endogenous insulin. You see that on the left side, that blue line is the human insulin, adults without diabetes. You see that when we eat a carb or any food, that how our pancreas is reacting to the food. And there is a peak in the insulin that then it just goes down up to 240 minutes. On the other hand, you see this, the purple line is the 12 units of inhaled insulin versus the 8 units of insulin Lispro is the comparison between the orange line. And you see that that's the inhaled insulin looks much more similar to the human insulin. And we will just come up with this, why these things are 12 and 8 and others, different of the numbers. So a little bit more the historical perspective. I didn't want to go too much before that current FDA approved the inhaled insulin. I started just history before the new inhaled insulin with the affinity 1 inhaled insulin in type 1 diabetes study. And you see that this is a non-inferiority study for 24 weeks. And in type 1 diabetes, the A1C was between 7.5 to 10. And the between group difference was A1C was 0.19%, which the FDA again non-inferiority margin was 0.4%. And the inhaled insulin people get compared to the subcutaneous rapid-acting analog with the basal insulin, you see that less hypoglycemia, weight gain, and with the inhaled insulin. But on the other hand, 5.7% of them discontinued inhaled insulin due to cough, and less people achieved with A1C less than 7% gold with the inhaled insulin on the other hand in this clinical trial. And if we go to our study that we did in 2018, the STUD study, this is an investigator-initiated study, and we did a multi-center in the United States with the inhaled insulin and randomized 4-week clinical trial that only for the adults and with 60 people with type 1 diabetes. And inhaled insulin group was a study group they used for all of their meal coverage. On the other hand, the insulin aspart were the control group. And A1C, the inclusion criteria was 6.5 to 10. And 34 people controlled and 26 people inhaled insulin. That's the randomized stratified by the A1C is more or less than 8. So this is the dose conversion chart from the FDA approved label that we used. Up to 4 units injectable people use the 4 units of inhaled insulin, and 5 to 8 use 8, 9 to 12, and it goes like this. And I will just explain in the later slides that inhaled insulin coming with the 4, 8, and 12 units cartridges. So, and then this is the dose conversion that they available. What we did, because that inhaled insulin is in and out, so faster insulin, but also its effect is significantly shorter comparison to the other injectable insulins. So we added a 1 hour or 2 hour corrections that if the blood sugar is at 1 hour or 2 hour, if more than 150, that they will be giving 4 or 8 units, depends on our protocol. And then most of the people are got additional 4 units of the inhaled insulin if their blood sugar is between 150 to 200. If their blood sugar is more than 200, then they gave 8 units or 4 units if they are still high. And that study is everybody was wearing CGM during all study in both groups. And you see that in this that it's a little bit confusing, but I will just explain that I put all of them it's actually 2 slides that all of them are in the 1 slide. The orange line is actually insulin aspart, that our control group, and the blue line is the inhaled insulin all group. If you see that if you compare them, both of them are at the 60 minutes and 90 minutes, then you see that it's statistically significantly better postprandial blood glucose with the all groups. And the other blue line, you see the dots, that inhaled insulin taking according to the correction protocol, which means that they used more than 90% of them used at least more than one supplementary dose. And the other one is that the people are underdosed significantly in the inhaled insulin and they use less correction than the protocol. And this is all based on about this one I'm talking about, their type 1 diabetes, in this TI dose corrections and if the 1 hour and 2 hours between 150, 200 and over 200. And if you see that this one is the, even after the 120 minutes, the people that use according to the protocol getting an additional dose actually achieved a better blood glucose after the meals. So we will all talk about this. What is this, getting less corrections? What is this? Why this some people didn't use and why and how can we, overcome these issues? So in the same study is that inhaled insulin taken according to the protocol, which are the people that are compliant to the protocol, that actually achieved so much better time in range, 2 more hours in time in range in inhaled insulin taken patients, and time in range increased from 53.8 to 62.5%, which was statistically significant. And time in hypoglycemia was 2.2 versus the 3.8%. If you see that the orange bar is the subcutaneous insulin, which is the other group comparison. The purple bar is the inhaled insulin that not taken according to the protocol, and the blue bar is the insulin taking the protocol according to the protocol. And this was the only study that showed a time in range benefit in 24 hours in a ultra rapid acting insulin. And again, that's the limitations are this was a 1-month study comparing to the other studies only used their CGM for 2 weeks and 2 weeks in this all 3 months study. And how about the postprandial glucose with the different meals? And you see that the comparison with the inhaled insulin taken according to the protocol versus the control group, there is a significant increase in this postprandial glucose breakfast and lunch, but we didn't see in dinner. And if you look at that, why actually it happened, and then we see that the dinners for the people really significantly underdosed for their meals, and they didn't give the insulin according to the protocol. And I will just talk about these all issues at the end of my talk. So if we come back to the Affinity 1 clinical trial with the, what's the hypoglycemia with the inhaled insulin, and you see that less hypoglycemia level 1 and level 2 with the inhaled insulin in the Affinity 1 post-hoc regression analysis, and then level 3, which is requiring the third-party assistance, which was, barely not significant, but if you see that level 1 and level 2 was statistically significantly less hypoglycemia patients, had in this with the inhaled insulin. So the postprandial hypoglycememia and the less hypoglycemia with inhaled insulin after 2 to 5 hours period after the meals. And if you look at the comparison part, and this the dark orange versus the light orange, and the dark blue versus the light blue or orange, whatever that you see the color is, it looks a little bit different in the two screen to me. And then if you see that the dark bar is the 2 to 5 hours and the light bars are the 0 to 2 hours. And if you see that actually less hypoglycemia for the postprandial blood sugars that you can see here. So how about the change in lung function with the inhaled insulin? And if you see that from the clinical trials that up to 2 years, patient had a small decline FP1 up to 40 milliliter, which is also an aging in the 5 to 10 years that we are also losing our lung capacity up to 40 milliliter. And it's all a reversible process when you do that. And there were no difference between the patients with type 1 and type 2 diabetes. And even though the people are younger, people can function and do, all their activities, sports and everything. We didn't get any issue with that, so much with their lung issues. So safety precautions with inhaled insulin and contraindications in the COPD and asthma patients. And you need to get a medical history, physical exam, and spirometry, which is an FP1 measurement before initiation. And you have to do the FP1 measurements after 6 months and then annually. And you have to consider discontinuation if the more than 20% decline in the FEV1 measurement. So this is kind of the current, the label information. And starting the inhaled insulin, again, I showed you already that the injection bolus dose conversion with the currently for the FDA approved label chart, that up to 4 units, 4, 5 to 8, 8, 9 to 12 is 12. And it comes with 3 different cartridges for 8 and 12 with different colors. And then the inhaler is that you can use it for multiple times and then you can change it. But then we realized that actually in that the studies that also be designed, that even that we are recommending patients in years ago that even though like a 1.5 dosing, the conversions are actually not enough. And the people are actually not correcting their blood sugar enough. And then there's a huge fear for hypoglycemia because they have never used that much amount of insulin, even though these are like apples and oranges in terms of the units. And that was the biggest problem in our studies that we did with inhaled insulins, that the people tend to underdose significantly. And then you see that even for the 1.5 dosing, that it's still significantly less than the current label information. So there is the dose comparison study. There is a very recent study, and they did this the dose 1, and this the label dosing that I showed you. That those 2 actually they give the 2 times of dosing, that is a 1 to 2 the conversion. Then you see that in the first hours that the 45 to 60 minutes there is like a significant increases in the postprandial glucose control. And then comparison to the label dosing, and then the hypoglycemia rates were very similar, and most of these people had actually the type 1 diabetes, and 2 times dosing group had so much better postprandial glucose. And so we believe that right now actually that the comparison should be actually almost to 1 to 2, other than this, the label information has to change at some point, and we are suggesting our patients that a little bit, higher doses. And there's a couple other small studies that I didn't include that ones, that is a small amount of people, and they, most of them are also showed that 1.5 to 2 comparison, the conversion actually works a little bit better. So how we measure the FEV1, which is a spirometry. We have a small spirometry if you have it in your clinic. Otherwise, the company supplies this one with the small devices. And there's a mouthpiece that you insert the mouthpiece and switch devices on. And you instruct the patient to exhale 3 times, and you record the best FEV1 value. And so you can just measure this one, record, and so you can just monitor it to 6 months and annually, as long as the patient is using this one. So how do we know that people are using the inhaled insulin properly, and how much they should be, using and exhaling and this insulin? So there's a small device, it's called BlueHale Pro. And the BlueHale is a small device that's an attachment that the patients can attach this one to their inhaler device, and which is with the Bluetooth enabled device that goes with their smartphone, and they can see that when they use it, and they can see that it's a green or red, and they can see that if they are doing it properly or not, are they doing too much or they are not getting enough. And this educates the patients on the correct dosing of the inhaled insulin technique and the handling of the inhaler, and provides patients with a visual display of their inhalation length and effort in a small phone app. It's a very helpful thing, we sometimes use in our clinic, and some of the people can use by themselves too, and it can just show them that actually how they are doing it properly. I think the education is key for the inhaled insulin. So if I show a real patient of my patient actually with the real CGM data, it's a 24-year-old female. She was a primary school teacher, and 8 years history of type 1 diabetes, no microvascular complications, and on 20 units of insulin glargine, 1 to 10 insulin carb ratio using insulin aspart, and using a real-time CGM. And last day once it was 8.6%. And it means that missing bolus insulin doses, especially at work, due to this, a common problem for my teacher patients actually for missing the lunch dose. And no time to wait 10 to 15 minutes for lunch at work, hesitant to use insulin pens at school, and afraid of being stigmatized by students, especially for the teacher. I think, this my observation is kind of a big deal. And you see that the patients actually see that that missing that most of the insulins are used. See clearly that this patient is either significant underdosing or not taking. For my impression is not taking, obviously, and she admits that not taking some of them, and especially at work. And then you see that the higher meals after the blood sugar. And if you see that 2 weeks of insulin aspart and the last 2 weeks that AGP data are compared with the 2 weeks of using the inhaled insulin, and at school, and I encouraged her to use it at every time at work. If you see that even for the only 2 weeks change, 4.7% to 48.8%, it's just increased the time in range. And then is also from 3.5% lows to 0.3%, even though I didn't change any basal insulin with only, I think that she was a little bit correcting after the dinner also and missing some of them and bolusing a little bit late and then correcting a little bit more with the rapid acting insulin, and it was just going a little bit low overnight, which there is no basal adjustment here. So if we see that even for a shorter period of time, you can see a little bit increase in time and range, I think it can be helpful for the right patients. So summary of inhaled insulin, again, this is all my personal opinion here. And then there are advantages and disadvantages, like everything, there are pros and cons. With my research experience and clinical experience, and this is like, you can agree and disagree, we can talk. And ultra rapid acting insulin, it's an in and out, faster than any insulin in the market. So it mimics the endogenous insulin production. It's a huge advantage. So better postprandial blood glucose if you use properly, and less risk of hypoglycemia because it also leaves the system very quickly. No needles, easy to carry and use, and you can just carry in your pocket very easily. And good for snack coverage. And then, some people are using this for their stop-borne highs if your blood sugar is over 300, 400. And some people are even using for their pump failures, or sometimes with the pump, even though it's not. There are some small study they also did, but I didn't include this one. I don't think it's published yet. And then ideal for patients cannot wait for 10 to 15 minutes to eat after injections, so they can just use the inhaled insulin as soon as they start eating. So disadvantages are requirement of the FEV1 testing. And I think that the next step should be removing this FEV1 testing at some point, but right now it's at the beginning 6 months and once a year. So, and I think the company supplies this one already, and that's a requirement for now. And you just monitor the FEV1 changes as long as no more than 20% decline, which we haven't had any person that left our study or the clinic because of the only FEV1 testing failure or any problem related to that. And sometimes high-fat protein meals may need additional dosing. If somebody eats a pizza, if they only dose once at the beginning, obviously they will need the additional dose. But even we see that in our patients that if we eat the pizza, obviously, it's not going to be probably one injection, even in a pump may not be enough. So I think you can handle this you can take another dose, properly after 1 hour or 2 hours, depends on how your blood sugars are doing. And people tend to underdose. My personal opinion, I think that's the biggest problem. And I think that at least 1.5 up to 2 times more dose is required to get a proper aspart or lispro comparison. And because people are seeing this for 8-12, and if they think that, I need to give 12 units, if somebody always get a 4 units or 6 units, or the last 10 years with the insulin aspart or lispro, they were like, I probably 12 units, let me get 8. And it means that actually, sometimes can be a little less than, actually is a 6 units of aspart, which is a 12 units of inhaled insulin. So I think that's a common problem. We also had this in this study that people significantly underdose despite all this, things. And you have to really educate the patients that, these are very different insulins. These dosings are very different. So you shouldn't be afraid of dosing a little bit higher because that's kind of a different thing. Confusion with dosing units, it's kind of, the same thing almost, and only available between the 4, 8, 12 units. And some people say, I'm just taking a little bit more or less, there is no like between forms. No pediatric indication yet, even though there's a pediatric studies going on right now in a multi-center study, and I don't think the results are announced yet. And sometimes the insurance coverage can be an issue with and all these insulins that I mentioned, that's the coverages and can be an issue with all of them actually, with the Fiasp and Lumjev and with the inhaled insulin too. And sometimes if the insurance is not covering, in how we do in Colorado, we send for a special pharmacy if they cannot do the prior authorization or if they cannot do the paperwork, and there is the companies helping with their free insulin and other things. And another thing that I just want to raise the attention is that because it's a rapid acting insulin doesn't mean more powerful. That's a misconception with the patients. They are just taking 4 units of inhaled insulin and it's a rapid acting insulin, but it's not decreasing my blood sugar because you only took literally 2 units of Novolog or Humalog. So you have to think about that. Fast doesn't mean more effective. So dosing is a different thing. And especially my personal suggestion is, and the CGMs that are reading every 1 minute, like Libre 3, especially if you take the inhaled insulin, then the numbers are 5 to 10 minutes later, turning to the other side very instantly. So the people are using the CGM for many years. They are not used to that. They are used to take their injection. It's going to be like 15 minutes, 30 minutes, 45 minutes, 1 hour, then they will see that their numbers are going down after a meal. So that something gives that false impression that, I will have a low blood sugar. So they just tend to eat. And they all say that, my CGM turns down very quickly when I use this insulin. So I will hit the low. So I'm just keep eating. So then their blood sugars are not going down. So again, fast doesn't mean more powerful. So you have to really think about how much the dose, it really depends on the dose. And the fast, you have to use this rapid acting insulin by the rules. And then you have to teach the patients that, okay, your CGM may turn down a little bit quicker. That's fine. Doesn't mean that you are going down from 200 to 50, probably you will go from 200 to 100. It's a little bit faster. And my suggestions, again, you have to explain and you have to know, and your staff know the PK/PD of the inhaled insulin, and you have to educate your patients about that. These things are different. And encourage to dose properly, not to underdose. And you have to train how to use the inhaler. There's a common problem that people are not using that inhaler also properly, and maybe using a BlueHale device that can be very helpful, especially for my younger patients. It's very helpful with everything. If you do anything in this new generation with an app, they really like it. And they were also, very happy about using an app with something. And identifying appropriate patients for better results, for the people are missing insulin or they want a little bit faster result with, or anybody can use. And exploring insurance coverage in your state with the discount options, and you can, communicate with the rep, and all others, company resources can be available. And follow-up plan for FP1 testing and dose adjustment. Who is going to, do the FP1 at 6 months, 1 year? Who is going to do those adjustments when you can just try to titrate up your dose? And that's my end of my talk, and I'll be happy to answer your questions. Thank you. Okay, any questions?
Hello, this is from Stephanie Crossan. Do you find that your patients using inhaled insulin use it exclusively or a mix of different rapid insulin, acting insulin, and
I need to repeat the question for the online people. The question is, are the people are using only the inhaled insulin or they can use the mixed insulin? I think both of them that we have. Some people are using only for the, for their very high snacks or some corrections, and sometimes with some stubborn highs, and they use their, regular, their injectable insulin most of the time. And some people are only using the inhaled insulin that, I think we have both of them. And some people are even using sometimes with the pumps too, even though that's nothing with that label, but, some people are using with that pump failures, and, if they're high, that the hybrid curve cannot handle that, so.
Thank you. And one more question. Do you find it works better for exercise?
The question is it helpful for exercise management? I think so. And especially we have younger people that athletes are, and especially after a lunch, if somebody's going to exercise, because it's almost 2 hours later, so in and out in the smaller doses. I think it can be helpful if, you can dose properly, that the risk of hypoglycemia can be a little bit less.
Thank you.
Very interesting. 2 questions. The first is, there have been studies that looked at effects of the illness, such as the respiratory illness. Would that be an option where we could switch back to injectable insulin? And then the second question is the FEV1 data. Is that with the 1x equivalent, or is it? I guess is the risk for the decrease FEV1 linear, or so if we're using for the 2x dosing, you see twice that change?
So I don't think, that's all the data is accumulated with, obviously, with the earlier data with, label that how much the insulin, and I don't think that we have enough information about, what's, that. So the only the COPD and asthma are for the label thing, but we don't have any issue with the people are, having a flu or something like that. Obviously the COVID time is different, if somebody's having, obviously, respiratory difficulties and other things, I don't think, how we can predict or, say that, oh, you should be using or you should not be using. And probably it's my opinion, if somebody's having some issues with their lungs for whatever the reason may be, stopping that in that, for a short period of time can be a little bit helpful. Doesn't mean that something is going to happen. I think we need more data. But I think that, overall, that it's we don't have any problem that people are stopping in real life, or because I have this, I have that. The people are discontinue reasons, or they cannot get it all about that misconception, misunderstanding, underdosing, insurance coverage, they cannot get all this kind of different reasons. But I almost never heard somebody says, oh, causes this. Even for the cough, even though in some of the earlier studies that most people, discontinued because of the cough in the either STAT study or the clinical practice in Barbara Davis Center adult clinic, we don't have any patients that I know that because of the cough, they stopped the medication. And for the linear or not, I think it really depends on the long term. It's it's really in time.
Did you have any patients, did you advise them differently on sick day management? And did you use management on insulin?
Not necessarily. Obviously, this is not an insulin to decrease your ketones, and or not an indication to when you're in DKA to use it. Obviously, you need a longer acting insulin, so on, you need more insulins, but it's all theoretical. You have to see about this perspective. If you get only one inhaler and try to treat your DKA, obviously it's not going to work. But if you are getting, every 2 hours, every 1 hour, I think that's a different thing. So obviously in their label and everything, it's not a treatment for DKA, and I think it's a legal and ethic language there. But again, I think this is what's the DKA's treatment in the hospital. We give the IV infusion drips and other things, right? It's nothing like you gave an injection and you give another injections like 12 hours, 20 hours later. I think that's the same mentality, because it's a fast-acting insulin. It's also relatively short-acting insulin. And I think that's one of the reasons that it may be an issue if it's not properly followed. I don't see as a problem if you do very properly. It may not be practical. That's a different discussion.
I appreciate the information about the 2 years showing that there was decrease in lung function. Do we have any longitudinal studies on that at all? That's after 10 years, and then follow up with patients that have expressed maybe fear about lung cancer, or thinking, growth hormone into lungs, and so they need longitudinal.
I think it's that there will be more data in the very long term, but I don't think there is as far as I know, that this the only information that are publicized that the company released. Then I don't think we have enough the very long term, because it's also this is not in the market for 20 years, right? I think it's still that relatively a new insulin, even though I think that nobody has an issue main problem so far. But I think if you're asking 10 years, 20 years, results, then I think we will need more time to see about these theoretical things. But in the studies that about lung cancer and other things, the people that were, and the smokers that in a handful of people that, got the lung cancer, but they were already a smoking history. So when somebody has a smoking history, I don't think we can say, oh, this is causing because of that. So.
Yeah, thanks. So I'm going to follow up on that one already. Great talk. The audience that remember people. And that relates back to that question is the longer term risk of this. And I agree, we all have many patients who are like, can I use it to top off if I have reported it's almost a 50-day patient? And definitely for people who aren't dosing, as you alluded to, is a great option. But I do think we definitely need longer term data before we recommend it, particularly in the younger population use it for the next 30 to 40 years. So I believe there's follow-up in terms of safety data, and I'm not being negative, it's exciting, but I think we do need to think about the potential risk and warn patients.
Yeah.
Hi, I'm Mary Peckham in my youth. I thought I had seen that there were two non-smokers who developed squamous cell cancer after lung cancer after this having participated in the study, even though the study had finished. Are you back to that?
So I don't know that much, how many people got after the smoking handful groups, but I think there is like, if there is a significantly causes some issues, I think that we will see that. But I agree for different reasons, for every medication and insulin, so everything we need to see really long-term data. Even the insulin collagen when first came, there was always like hundreds of publications, is it cause of cancer or not cancer? Because cancer is also an increased risk in the type 2 diabetes and obesity, which is already a proven thing. So is it the chicken is coming from egg or is egg is coming from chicken? I think that's one of the reason is that the insulin, way how you get it, or the insulin is causing this or not. I think it's a far more complicated thing. In a very long-term data can show that a little bit better. But at least in the short term and midterm, I don't see there is a huge issue that it raises a problem for we are using in adults. But again, in the long term, we will see for all medications, and it's not only specific to inhaled insulin, I believe for everything.
Okay.